Hello everyone. Thanks for joining me on this virtual training on person-centered care, dementia training, behavioral health, and cultural competency. It's been about a year since the social work department put this training on, and a lot has changed in that time. Thank you for your dedication and hard work during this trying time. All of us had made sacrifices over the last 10 months, not being with friends or family, foregoing special events, and many more. Despite it all, you continue to show up and do your very best in taking care of our veterans' physical and emotional needs. You might not realize it, but your efforts saved lives. Your efforts continue to make an impact in and outside this building. Thank you for being here, looking out for your residents, and being safe. You are all heroes. Today, I'll be talking with you about how we can apply person-centered care to dementia and behavioral health management. In addition to that, I will also be discussing cultural competency and how being mindful of who our residents really are will not only improve their last chapter of life, but improve our overall job satisfaction. The first overarching concept from today's presentation is respect and value. Each resident who lives here is a full member of our society. They are not a number or a diagnosis. They are a father, a grandfather, historian, AA member, veteran, or a spouse of a veteran who many people care about. The second theme is individualized care over time. We have the opportunity to care for our residents for days, weeks, and years. Just like you and I, our physical and emotional needs change over time. What met your needs yesterday might not meet your needs today. Our residents' physical abilities change, and we need to adapt in a manner that continues to provide honor, respect, dignity, and self-worth. The third theme is perspective. Each resident comes from a different background that is unique to them. Some may like to listen to their radio in their room, and some may want to attend every event possible. It is invaluable to know and understand our residents' perception of care. Do they want to be woken up for medications, or would they rather be left sleeping? Do they enjoy quieter spaces? Are they a joke teller? Or what can we glean from their cultural values that will improve their lives? And fourth is social engagement. How can we create opportunities for our residents that allow them to feel connected to us all? Most of our residents are BSU fans, although without a head coach and losing to San Jose State, the Vandals are looking mighty tempting. But beyond that, are there ways we can share a bit of ourselves in order to create enriching bonds with our residents? Can we connect residents with similar likes, preferences, and values in order to create opportunities for friendship and camaraderie? So we're going to start off by talking about how person-centered care and dementia go hand in hand. We'll talk about how our language is important. When we talk about our residents with dementia, it's important to recognize that they are a person first and they are not identified by their diagnosis. Remember that our residents are people first. They are not a feeder, they are a person who needs assistance with eating. They are not demented, they are a person living with dementia. Phrases like these, or a few cards short of a full deck, or a few cups short of a tea set, are not only disempowering, but they strongly influence the way we treat and care for our residents. Statements like those provide no context or descriptions to our coworkers regarding the important cares they're providing. If I were to say to you, Mr. Jones is a few beers short of a six-pack, he gets confused at night, but he's okay. How might you interpret that? How would your peer interpret that? Would it be the same? How about if I were to say to you, Mr. Jones is living with dementia. He does really well with simpler tasks like brushing his hair, wiping his mouth, and he understands facial cues. He was a former zoologist, and it's helpful at night when he gets confused because he forgets where he's at, he forgets where his wife's at, and he doesn't recognize who people are. If you draw on those life experiences of being a zoologist and gardening and talking about animals to help redirect him, which might be more successful? In that same situation, put yourself in Mr. Jones's shoes. Listening to those staff members talk about him, would one discussion of his situation be more respectful? Sure. Would one discussion of him make him feel valued, empowered, and cared for? Absolutely. When you put yourself in the shoes of someone with dementia, who uses incorrect words or is unable to find the word they're looking for, It can be really frustrating. If every sentence you attempted, the person looked at you confused, sometimes using the words that they use can help them seamlessly obtain their goal. Let them use a shoe to call their loved one. You and I know it's a phone, but it might not be helpful to correct them. Living in their world might also include going along with a confusing statement. We have cared for people who said they owned every bank and government in the world. Correcting them was not going to change things. It was better to go along with it. I would say to him, "What an important task you have running all those people. While I check your room, how about you tell me what it's like running all those businesses?" We can also use person-centered care for our residents with dementia when they experience something outside of their normal. Has there ever been a time where a resident you cared for maybe did something out of character? Maybe it was a crisis, like throwing things, yelling, cussing, grabbing, or tearfulness. Maybe it was a fall, or agitated in the evening, increased confusion on where their wife is at. How do we get in front of these? We get in front of these by getting to know our residents. If we know that Mr. Jones is going to call his wife every evening, but has fallen when attempted to do that, it would be helpful to assist with that phone call before he falls. There are other times we care for people with dementia, and an action occurs, but they're unable to tell us what the precipitating event was. Cares can be extremely difficult with people with dementia. What things could we be doing before cares to help the cares go smoother? Are there songs that help ease the resident? Are there certain staff members they like? Is there something in their life that we can engage with them about to improve the feeling of safety? And that brings me to my next point, a reorientation based on their life, experience, and habits. Getting to know your residents or walking alongside them will allow us to better understand and interpret their needs. What did they do before they moved in here? Did they read the paper? Did they bird watch? Did they start the day with a cup of coffee? How might their occupation apply to their life in the nursing home? What provided them with meaning? Was it their family? Was it their career, exercise, or hobbies? Were they a woodworker, a metalsmith, a book reader, a car enthusiast, a BSU fan, or a foodie? How can we use these little pieces of knowledge to not only enhance our clients' lives, but also create a bond between them, give them meaning, and allow them to capture what is so near and dear to them? I often hear residents say things like, "I really like a certain staff member. They just seem to get me. I can relate to them." For people with dementia, they can remember the faces of staff who give them those good feelings inside. It bodes very well for future interactions. Think about a resident with moderate to severe dementia. You're going to start to engage with them. They forgot who you are and don't recall what you're going to do, but you start off by saying, "Mr. Jones, so good to see you. I was hoping that I could provide you with a certain care, or maybe talk with you. But before that, I recall you working on a Ford Mustang before you moved in here. Didn't you have one in your garage? What was that like?" Helping someone with dementia re-experience their identity promotes your relationship with them and allows you both to grow. The resident gets to experience joy and meaning, which no matter where they are at in the lifespan is invaluable. The feeling that someone who you don't really recall, but seems like they know you and seems like they care for you, also promotes their feeling of safety, which for people who have dementia can be touch and go at times. The next topic I'd like to cover is behavioral health. We have the opportunity to care for residents who have lived long and exciting lives. Travelers, farmers, technicians, pilots, and golfers. Their lives incurred ups and downs just like everyone else. Some have experienced the heartache of losing a child or losing a friend in battle. Some of them have broken relationships with their family. In addition, all of our residents have lost physical abilities and some independence. They face ailments that jeopardize their longevity. There are some of our residents who also live with behavioral health. Some of the more common behavioral health diagnoses we see here at the Veterans Home are major depressive disorder, post-traumatic stress disorder, schizophrenia, bipolar disorder, and behavioral and psychological symptoms of dementia. Major depressive disorder includes the symptoms of sadness or loss of interest. It also includes changes in sleep, appetite, energy level, concentration, or self-esteem. Individuals who live with depression also have thoughts of suicide from time to time. Post-traumatic stress disorder includes nightmares or unwanted memories of the trauma, avoidance of situations that bring back memories of the trauma, heightened reactions, anxiety, or depressed mood. Individuals who live with schizophrenia have thoughts or experiences that seem out of touch with reality, disorganized speech, decreased participation in daily activities, delusions, hallucinations, frenzied speaking, disjointed thoughts, or paranoia. Individuals living with bipolar disorder have manic episodes that include high energy, reduced need for sleep, and loss of touch with reality. They also exhibit depressive episodes, which include low energy, low motivation, lost interest in daily activities. Sometimes these mood episodes can last days to months. Now, individuals with behavioral and psychological symptoms of dementia have symptoms of agitation, restlessness, pacing and wandering, anxiety, elation, irritability, depression, apathy, and disinhibition. Now, all of our residents deserve quality care. Our residents who live with behavioral health need care that is congruent with who they are and alongside their values. So what does that mean? And how can we best care for our veterans who live with behavioral health? Continuing on with patient-centered care and behavioral health, it's about giving our residents control over their services. It means putting a greater emphasis on our residents' involvement in determining the goals of treatment that are meaningful to them and at the nature of their care. Meaningful goals for all residents generally go beyond symptoms to include quality of life, functioning, and a sense of hope and self-efficacy. Patient-centered care isn't just about putting the resident at the center of the care equation. Rather, it shifts the balance of authority and responsibility of the provider-resident relationship and incorporates shared decision-making between the provider and the resident, particularly when it comes to treatment. When I say treatment, I mean treatment in the broad sense. This isn't just talking about oncology or what to do for your heart if you have congestive heart failure. It's involving cares around food, decisions around when they want a bath or when a resident wants a shower. It involves decisions around every aspect here in the nursing home, trying to empower our residents by sharing decisions with them. Shared decision-making is defined as a collaborative process that allows a resident and their care providers to make healthcare decisions together, taking into account the best evidence available, as well as the resident's values and preferences. Practicing shared decision-making requires that the providers assess the resident's interest in participating in those decisions, providing information to them on the risks and benefits of specific treatments or approaches in an understandable format and dialogue with the patient about their choices. Now, shared decision-making does not mean that care team providers don't make strong recommendations or encouragements. Rather, it means that those recommendations need to be reconciled with the residents' views and choices. Now that we've given our residents control over their health care, now it's our time to empower our residents. Empowering residents to be active participants in their care often requires educating them about their disorder and options for therapy to ensure that they are prepared to ask relevant questions and understand the answers. Empowering our residents includes focusing on their strengths and not their limitations. Certainly, empowering our residents is difficult when they have cognitive and decision-making impairments. But it's our job to develop the means to facilitate this mode of communication with our residents and their participation in care. Sometimes this might look like incorporating their family in their care and their decision making. The environment of the nursing home can be disempowering and can feel unsupportive. When you have wonderful staff taking care of you, decisions aren't really important because they're already done for you. This can be a disservice for our veterans who suffer from major mental health issues. Depression could get worse when you feel like you have no options and no choices and your life is already predestined. It's important for us to educate ourselves on what feels supportive and what doesn't for each of our veterans who struggle with these mental health diagnoses. Questions that we could ask them or their families. What's their background? What are their interests? What are they good at? A question that my boss likes to ask is, what are you famous for? What makes them feel supportive? What makes them feel happy? Or what makes them feel scared or fearful or frightened or disempowered? It's also important to be mindful of the language and attitudes we use around mental health. There's some extremely distasteful and dehumanizing language being used outside of this place that casts shade on those who struggle with their mental health. I've heard people being called lazy or moody or worthless, crazy, loony, strange, or a waste. Now, I don't hear those types of words being used here, but we can use language that expresses how a resident is acting or where they're at today. For example, if I was talking to another coworker about a resident, I might say, John's having a difficult time today. He yelled at me and threw his meal on the ground. Patty tried to bite me when I tried to transfer out of the bed. Joseph's thoughts are scattered today. He was jumping from topic to topic, and he was just tough to redirect. Richard had some high demands of me today. When I wasn't able to accomplish them as he wanted, he started to call me names. We can be honest and respectful at the same time. Our next section is on cultural competency. Cultural competency is defined as the ability of providers and organizations to effectively deliver healthcare services that meet the social, cultural, and linguistic needs of patients. Many of you might have noticed that the residents we care for are a homogeneous group: Caucasian, elderly, male, and veteran. In addition, maybe you have thought that culturally, because of those 4 factors, our residents have very similar values. Let's think about that for a second. Most of our residents are veterans, and veterans' culture includes teamwork, selflessness, shared goals, and perhaps most central, being of service to others, measuring one's worth by how well one serves others selflessly. Are those all shared amongst our residents? Think about this. Some common American values are personal control, change as a positive, time being valuable, independence and privacy, self-help, competition, optimism, casualness, honesty, and materialism. Do all those resonate with you? What I'm trying to say is that even within a group of people who seem similar, there are significant cultural differences among them. By 2050, racial and ethnic minorities will comprise 35% of the over 65-year-old population in America. By 2050, it is expected that 1 in 5 Americans, 20%, will be elderly. In the very near future, we will be seeing a more diverse, older population in our veterans' home. Older patients with chronic diseases may need to make multiple and complex decisions about the management of their conditions. Racial and ethnic minorities are also more likely to have lower levels of literacy, often due to cultural and language barriers and differing educational opportunities. So what can we do to be more culturally competent? Well, we become more curious, empathetic, respectful, and humble. Those are some of the basic attitudes that have the potential to help the clinical relationship and to yield useful information about a patient's individual beliefs and preferences. An approach that focuses on inquiry, reflection, and analysis throughout the care process is most useful for acknowledging that culture is just one of the many factors that influence an individual's healthcare and practices. As we become more curious, empathetic, respectful, and humble towards a resident's culture, it allows us to be more aware of the influences that our culture factors have on residents, staff, and the relationship between them. It also allows us to recognize personal biases against people of different cultures. They encourage us to be more respectful and tolerant for cultural differences. And finally, those 4 basic attitudes encourage us to be more accepting and responsible to combat racism, classism, ageism, sexism, homophobia, and other kinds of biases and discrimination that occur in healthcare settings. This concludes the Social Work Department's presentation on person-centered care, dementia training, behavioral health, and cultural competency. I hope it has provided you with some ideas on how you can improve the quality of care you deliver. The better you know the resident you care for, the more the resident will feel honored and respected. By taking an interest in who our residents are, you are creating bonds that allow residents to feel more like people instead of patients.